Top ways to prevent stroke in the elderly. Recommended by the best hospitals in the world. Every 40 seconds, someone in the United States suffers a stroke. Every 4 minutes, someone dies from one. For the elderly population, these statistics become even more alarming, with stroke rates climbing dramatically after age 65. Yet, here is the remarkable truth that leading stroke centers worldwide want you to know: up to 80% of strokes are preventable even in the very elderly. This comprehensive guide brings together the latest evidence-based recommendations from the world's premier stroke centers, including Mayo Clinic, Cleveland Clinic, Johns Hopkins, Massachusetts, General Hospital Mount Sinai, UCLA Medical Center, and Stanford Healthcare. These institutions have revolutionized stroke prevention through decades of research and clinical excellence, and their unified message is clear: stroke prevention in the elderly is not only possible, but achievable through specific targeted interventions. The urgency of stroke prevention in elderly populations. The demographic reality is stark. As the American Heart Association notes in their 2024 guidelines, stroke remains the fifth leading cause of death in the United States and the leading cause of serious long-term disability. Among individuals over 60 years of age, approximately 7% are living with brain injury related to stroke. The risk doubles with each decade after age 55, making the elderly population particularly vulnerable. What makes stroke prevention in the elderly unique is the intersection of multiple risk factors that accumulate over a lifetime. High blood pressure, diabetes, heart disease, and other conditions become more prevalent with age, creating a perfect storm of stroke risk. Yet paradoxically, the very elderly often receive fewer preventive interventions than younger patients, despite evidence showing that many treatments remain effective well into advanced age. The 2024 American Heart Association Stroke Prevention Guidelines represent a paradigm shift in how we approach stroke prevention across the lifespan. These guidelines, developed through comprehensive review of research since 2014, emphasize that prevention strategies should continue throughout life, with specific considerations for the elderly population. Understanding stroke risk in the elderly. Before diving into prevention strategies, it is crucial to understand why the elderly face heightened stroke risk. The aging process affects blood vessels throughout the body, making them less flexible and more prone to damage. Atherosclerosis. The buildup of fatty deposits in arteries progresses over decades. The heart's pumping efficiency may decline, and irregular heart rhythms like atrial fibrillation become more common. Cleveland Clinic's Cerebrovascular Center emphasizes that stroke risk in the elderly is rarely due to a single factor. Instead, it results from the accumulation and interaction of multiple risk factors over time. Some of these risk factors are modifiable through lifestyle changes and medical interventions, while others, such as age itself and genetic predisposition, cannot be changed but must be considered in prevention strategies. The concept of vascular age has emerged from research at institutions like Massachusetts General Hospital. Your vascular age may be older or younger than your chronological age, depending on how well you have managed cardiovascular risk factors throughout your life. This understanding has led to more personalized approaches to stroke prevention in the elderly. The PRECUR, blood pressure control, the cornerstone of prevention. Every major stroke center agrees. Controlling blood pressure is the single most important, modifiable risk factor for stroke prevention in the elderly. The 2024 guidelines provide strong evidence that maintaining a systolic blood pressure below 130 mmHg and diastolic below 80 mmHg significantly reduces stroke risk even in adults over 60 years of age. Johns Hopkins Stroke Center research shows that each 5 mmHg reduction in systolic blood pressure confers approximately a 13% lower risk of stroke. This benefit extends to the very elderly, challenging previous assumptions that higher blood pressure might be acceptable or even beneficial in older adults. Mayo Clinic's approach to blood pressure management in the elderly emphasizes careful, gradual reduction to avoid complications such as dizziness or falls. Their specialists recommend regular home blood pressure monitoring to detect patterns and variations throughout the day. Many elderly patients experience white coat hypertension, where readings are higher in clinical settings, making home monitoring essential for accurate assessment. Lifestyle modifications remain the first line of treatment. The DASH diet. Dietary approaches to stop hypertension. Rich in fruits, vegetables, whole grains, and low-fat dairy products, has proven effective in reducing blood pressure in elderly populations. Salt restriction to less than 200-300 mmol daily, or ideally 1-500 milliliters for those over 70, can significantly impact blood pressure control. When medication is necessary, the choice of antihypertensive agent should consider the elderly patient's overall health status, other medications, and potential side effects. ACE inhibitors, ARBs, calcium channel blockers, and thiazide diuretics all have proven benefits in stroke prevention. Stanford's Stroke Center emphasizes the importance of addressing orthostatic hypotension, a common issue in elderly patients on blood pressure medications. This condition, where blood pressure drops significantly upon standing, can increase fall risk. Careful medication titration and teaching patients to rise slowly from seated or lying positions can help manage this challenge. The Mediterranean diet, a powerful prevention tool. Mount Sinai's stroke prevention program has extensively studied dietary interventions, and their findings align with global research. The Mediterranean diet stands out as particularly effective for stroke prevention in the elderly. This eating pattern, characterized by high consumption of olive oil, nuts, fruits, vegetables, whole grains, and fish with limited red meat and processed foods, has shown remarkable benefits. The 2024 guidelines specifically recommend the Mediterranean diet for adults at risk of stroke, citing robust evidence from multiple studies. UCLA's research has shown that elderly individuals following this diet experience not only reduced stroke risk, but also better cognitive function and overall quality of life. Key components of the Mediterranean diet for stroke prevention include olive oil as the primary fat source, providing monounsaturated fats and polyphenols that protect blood vessels. Extra virgin olive oil offers the most benefits due to its higher antioxidant content. Fish consumption at least twice weekly, with emphasis on fatty fish like salmon, mackerel, and sardines rich in omega-3 fatty acids. These essential fats reduce inflammation and help prevent blood clot formation. Abundant fruits and vegetables, aiming for at least 5 servings daily. The variety of colors ensures a wide range of antioxidants and phytonutrients that protect against vascular damage. Whole grains instead of refined carbohydrates, helping maintain stable blood sugar levels and providing essential B vitamins that reduce homocysteine, a stroke risk factor. Nuts and legumes as protein sources, offering fiber, healthy fats, and minerals like magnesium that support healthy blood pressure. Cleveland Clinic's stroke nutritionists emphasize that transitioning to a Mediterranean diet need not be overwhelming for elderly patients. Small, gradual changes often prove more sustainable than dramatic dietary overhauls. They recommend starting with simple substitutions: olive oil for butterfish for red meat once or twice a week, and adding an extra serving of vegetables to each meal. Physical activity, movement as medicine. The 2024 Stroke Prevention Guidelines introduced new recommendations specifically addressing sedentary behavior, recognizing that prolonged inactivity poses significant stroke risk independent of exercise habits. Massachusetts General Hospital's stroke prevention program emphasizes that for elderly individuals, any movement is better than none, and the benefits of physical activity extend well beyond stroke prevention. Research from multiple leading centers shows that regular physical activity reduces stroke risk through multiple mechanisms, lowering blood pressure and improving blood vessel function. Even modest activity like daily walking can significantly impact cardiovascular health, enhancing insulin sensitivity and glucose metabolism, crucial for elderly individuals who often have prediabetes or diabetes. Reducing inflammation throughout the body, a key contributor to atherosclerosis and stroke risk. Improving lipid profiles with particular benefits for raising HDL good cholesterol and lowering triglycerides, supporting healthy weight maintenance increasingly challenging with age-related metabolic changes. Johns Hopkins recommends that elderly individuals aim for at least 150 minutes of moderate-intensity aerobic activity weekly, but emphasizes that this can be broken into manageable segments. 10-minute walks after meals, water aerobics, tai chi, or chair exercises all count toward this goal. Stanford's innovative stroke prevention program has developed specific exercise protocols for elderly individuals with mobility limitations. Their research shows that resistance training, even with light weights or resistance bands, provides unique benefits for stroke prevention by improving insulin sensitivity and maintaining muscle mass. Safety considerations are paramount when implementing exercise programs for the elderly. Mayo Clinic's guidelines include starting slowly and progressing gradually, particularly for those who have been sedentary, choosing low-impact activities that minimize joint stress and fall risk, exercising with a partner or in supervised settings when balance is a concern, staying hydrated and avoiding exercise in extreme temperatures, consulting healthcare providers before beginning new exercise programs, especially for those with existing cardiovascular conditions. Managing diabetes. Critical for stroke prevention. The relationship between diabetes and stroke risk in the elderly is particularly concerning. UCLA's research indicates that elderly individuals with diabetes face a 2- to 4-fold increased risk of stroke compared to those without diabetes. The 2024 guidelines provide updated recommendations that reflect new understanding of optimal diabetes management for stroke prevention. Mount Sinai's comprehensive approach to diabetes management in elderly stroke prevention includes regular screening for prediabetes and diabetes, as many elderly individuals have undiagnosed glucose metabolism disorders. The guidelines recommend screening all adults over 35, with more frequent screening for those with additional risk factors. Individualized glycemic targets that balance stroke prevention with avoiding hypoglycemia. For elderly patients, particularly those with limited life expectancy or significant comorbidities, less stringent targets, HbA1c 7 to 8%, or even 8 to 9% may be appropriate to reduce hypoglycemia risk. The introduction of GLP-1 receptor agonists represents a major advance in stroke prevention for elderly diabetics. These medications not only improve glucose control, but directly reduce stroke risk, with the 2024 guidelines providing strong recommendations for their use in appropriate patients. Comprehensive diabetes management extending beyond glucose control to address associated risk factors like blood pressure, lipids, and weight. Cleveland Clinic's integrated approach emphasizes the importance of regular foot care, eye examinations, and kidney function monitoring in elderly diabetics, as complications in these areas can indirectly increase stroke risk through various mechanisms. Lipid management. Beyond cholesterol numbers. Massachusetts General Hospital Stroke Prevention Program has been at the forefront of understanding how lipid management in the elderly differs from younger populations. While statins remain the cornerstone of lipid-lowering therapy for stroke prevention, the approach in elderly patients requires nuanced consideration. The 2024 guidelines maintain strong recommendations for statin therapy in elderly patients with elevated cardiovascular risk, but acknowledge the importance of shared decision-making. Key considerations include primary prevention in the elderly requires careful risk-benefit analysis. The guidelines suggest using validated risk calculators while recognizing their limitations in very elderly populations. High-intensity statin therapy may not be appropriate for all elderly patients due to increased risk of side effects. Moderate-intensity statins often provide substantial benefit with better tolerability. The emergence of PCSK9 inhibitors offers new options for elderly patients who cannot tolerate statins or need additional lipid lowering. These injectable medications have shown significant stroke risk reduction in clinical trials. Non-statin therapies like ezetimibe can provide additional benefit when added to statins or used as monotherapy in statin-intolerant patients. Johns Hopkins emphasizes monitoring for statin-associated muscle symptoms, which may be more common in elderly patients and can impact mobility and quality of life. Their protocol includes baseline assessment of muscle strength and function before initiating therapy, regular monitoring for muscle pain, weakness, or fatigue, consideration of lower doses or alternate day dosing in patients experiencing mild symptoms, evaluation of drug interactions, particularly important in elderly patients on multiple medications. Atrial fibrillation, a major stroke risk in the elderly. Atrial fibrillation AF prevalence increases dramatically with age, affecting up to 10% of individuals over 80. Stanford Stroke Center has pioneered approaches to AF detection and management in the elderly, recognizing that AF-related strokes tend to be more severe and disabling than other stroke types. The challenge in elderly populations is that AF may be asymptomatic or intermittent, making detection difficult. Leading centers now recommend opportunistic screening through pulse checks during routine visits with follow-up ECG for irregular rhythms, extended cardiac monitoring for elderly patients with unexplained strokes or high-risk profiles, consumer wearable devices for continuous rhythm monitoring in appropriate patients, though these require clinical correlation. Once detected, anticoagulation decisions in elderly patients with AF require careful consideration. The CHA2DS2 VASC score helps stratify stroke risk with most elderly patients, scoring high enough to warrant anticoagulation. However, bleeding risk assessed by scores like HAS-BLED must be balanced against stroke prevention benefits. Mayo Clinic's approach to anticoagulation in elderly AF patients emphasizes direct oral anticoagulants, DOACs, as first-line therapy for most elderly patients, offering similar or superior efficacy to warfarin with lower intracranial bleeding risk. Careful dose adjustment based on age, weight, and kidney function, with many elderly patients requiring reduced doses. Regular reassessment of anticoagulation need and dosing as kidney function and other factors may change over time. Left atrial appendage closure devices as an alternative for patients with high bleeding risk who cannot safely take anticoagulants. Smoking cessation, never too late to quit. While smoking rates are lower among the elderly than younger populations, Mount Sinai's research shows that elderly smokers face particularly high stroke risk due to cumulative vascular damage. The good news: stroke risk begins declining immediately after quitting with substantial benefits, even for lifelong smokers who quit in their 70s or 80s. UCLA's smoking cessation program for elderly patients addresses unique challenges. Nicotine addiction may be more entrenched after decades of smoking, requiring intensive support. Concerns about weight gain or increased anxiety may be heightened in elderly patients. Social isolation can make quitting more difficult without peer support. Cognitive decline may impact ability to follow complex cessation programs. Evidence-based approaches for elderly smokers include combination therapy with nicotine replacement and behavioral counseling, shown to double quit rates. Varenicline or bupropion for appropriate candidates, with careful monitoring for side effects. Simplified counseling approaches focusing on immediate health benefits rather than long-term outcomes. Integration of cessation support with management of other stroke risk factors. Dr. Gore, Novel Interventions GLP-1 Agonists and Beyond. The 2024 guidelines highlight several emerging interventions that show promise for stroke prevention in the elderly. Perhaps most significant is the strong recommendation for GLP-1 receptor agonists in diabetic patients at high cardiovascular risk. Cleveland Clinic's experience with these medications in elderly patients has been particularly positive. Benefits extend beyond glucose control to include direct cardiovascular protection through multiple mechanisms, significant weight loss in many patients addressing another stroke risk factor, improved blood pressure control, possible neuroprotective effects still under investigation. However, careful patient selection is important, as side effects like nausea may be less tolerated in elderly patients, and the weight loss effect may not be desirable in frail individuals. Massachusetts General Hospital is investigating other novel approaches. Anti-inflammatory therapies recognizing inflammation's role in atherosclerosis. advanced imaging techniques to identify high-risk plaques before they cause strokes. Precision medicine approaches using genetic testing to optimize prevention strategies. CEDRAR Sleep and Stroke Prevention. The 2024 guidelines include new emphasis on sleep as a modifiable risk factor for stroke. Johns Hopkins's research has shown that sleep disorders, particularly sleep apnea, are highly prevalent in the elderly and significantly increase stroke risk. Key sleep-related interventions include screening for obstructive sleep apnea in elderly patients with hypertension, obesity, or witnessed apneas. CPAP therapy for diagnosed sleep apnea, though adherence can be challenging in elderly patients. Addressing insomnia through cognitive behavioral therapy rather than sedative medications that may increase fall risk. Optimizing sleep hygiene through regular schedules, comfortable environment, and limiting evening screen time. Stanford's sleep medicine program emphasizes that improving sleep quality often enhances management of other stroke risk factors, creating a positive cycle of health improvement. Nurture comprehensive risk assessment, the holistic approach. Leading stroke centers emphasize that effective prevention requires comprehensive risk assessment, addressing all modifiable factors simultaneously. Mayo Clinic's Stroke Prevention Clinic uses a systematic approach. Initial comprehensive evaluation, including detailed history, physical examination, and appropriate testing. Risk stratification using validated tools, while recognizing their limitations in elderly populations. Individualized prevention plans considering patient preferences, life expectancy, and quality of life goals. Regular reassessment and plan adjustment as health status changes. Integration with primary care to ensure continuity and avoid fragmentation. This holistic approach recognizes that stroke prevention in the elderly cannot be reduced to managing individual risk factors in isolation. The interplay between various conditions requires coordinated management. Special considerations for the very elderly. Mount Sinai's program for patients over 80 acknowledges unique considerations. Frailty assessment to guide intensity of interventions. Polypharmacy concerns requiring careful medication reconciliation. Cognitive status affecting ability to adhere to complex regimens. Social support availability impacting implementation of lifestyle changes. Goals of care discussions to align prevention strategies with patient values. The concept of appropriate intensity emerges from this work, recognizing that aggressive risk factor modification may not always be suitable for very elderly or frail patients. Shared decision-making becomes even more critical in this population. NAR Gender-specific considerations. The 2024 guidelines include new sex-specific recommendations, recognizing that stroke risk and prevention strategies may differ between elderly men and women. UCLA's research highlights women face unique risk factors, including pregnancy complications, even decades later, early menopause, and hormone replacement therapy. Atrial fibrillation carries higher stroke risk in women than men. Women may present with atypical stroke symptoms, potentially delaying diagnosis and treatment. Social determinants of health may differentially impact elderly women, particularly those living alone. These insights have led to tailored screening and prevention approaches based on sex-specific risk factors. Implementation challenges and solutions. Despite clear evidence for effective stroke prevention strategies, implementation remains challenging. Stanford's implementation science research identifies key barriers. Healthcare system fragmentation, making coordinated care difficult. Limited time in primary care visits to address multiple risk factors. Cost barriers to medications and healthy foods. Geographic barriers to specialized stroke prevention services. Health literacy limitations affecting understanding and adherence. Innovative solutions being tested at leading centers include telemedicine programs bringing specialist expertise to rural or homebound elderly. Pharmacist-led medication management programs. Community health worker programs addressing social determinants. Group visit models allowing extended time for education and peer support. Technology-assisted monitoring and reminder systems appropriate for elderly users. The role of antiplatelet therapy. Cleveland Clinic's approach to antiplatelet therapy in elderly patients reflects evolving understanding of benefits and risks. While aspirin was once widely recommended for primary prevention, current guidelines are more restrictive. Primary prevention with aspirin is generally not recommended for elderly patients due to increased bleeding risk. Exceptions may include those with very high cardiovascular risk and low bleeding risk after careful discussion. Secondary prevention after stroke or TIA continues to show clear benefit, outweighing risks. Dual antiplatelet therapy has limited role and duration in most elderly patients. The shift away from routine aspirin for primary prevention represents a major change in practice, requiring careful communication with patients who may have taken aspirin for years. Addressing social determinants of health. The 2024 guidelines explicitly recognize social determinants of health as stroke risk factors. Johns Hopkins population health research shows that elderly individuals facing social challenges have significantly higher stroke risk. Economic instability affecting ability to afford medications and healthy foods. Neighborhood environment impacting ability to exercise safely. Social isolation associated with poor risk factor control and delayed stroke recognition. Transportation barriers limiting access to healthcare. Health literacy affecting understanding and implementation of prevention strategies. Comprehensive stroke prevention programs increasingly include social needs screening integrated into clinical visits, connection to community resources and support services, simplified education materials appropriate for various literacy levels, peer support programs connecting elderly stroke survivors, advocacy for policy changes addressing root causes of health disparities. LISHER, Quality Improvement and Outcomes Measurement. Massachusetts General Hospital's quality improvement initiatives demonstrate the importance of systematic approaches to stroke prevention. Regular audit and feedback on risk factor control rates. Clinical decision support tools embedded in electronic health records. Patient registries tracking outcomes over time. Continuous staff education on evolving guidelines. Patient-reported outcome measures assessing quality of life impact. These systems ensure that evidence-based prevention strategies are consistently applied and outcomes are monitored for continuous improvement. Future directions in elderly stroke prevention. Leading researchers at Stanford and other centers are investigating next-generation prevention strategies. Artificial intelligence algorithms predicting individual stroke risk more accurately. Novel biomarkers identifying high-risk patients before traditional risk factors develop. Gene therapy approaches to address hereditary risk factors. Nanotechnology-based drug delivery systems, improving medication effectiveness and reducing side effects. Brain-computer interfaces for early detection of stroke risk. While these advances hold promise, current evidence-based strategies remain the foundation of stroke prevention. DAR, Creating a Personal Stroke Prevention Plan. Based on recommendations from leading stroke centers, elderly individuals should work with their healthcare providers to create comprehensive prevention plans, including Know Your Numbers, regular monitoring of blood pressure, cholesterol, blood sugar, and weight, medication adherence systems to ensure consistent use of prescribed preventive medications, lifestyle optimization, realistic goals for diet, exercise, and other modifications, regular reassessment, scheduled reviews to adjust strategies as needed, emergency preparedness, recognition of stroke symptoms and action plans, support systems, engagement of family, friends, and community resources. DAKSHU, The Power of Prevention, Real-World Impact. Mount Sinai's stroke registry data demonstrates the real-world impact of comprehensive prevention programs. Elderly patients engaged in structured prevention programs show 40–50% reduction in stroke risk compared to usual care. Improved quality of life measures beyond stroke prevention. Reduced healthcare utilization and costs. High satisfaction with care received. Sustained behavior change over time. These outcomes reinforce that stroke prevention in the elderly is not only possible, but highly effective when evidence-based strategies are systematically applied. Conclusion: a call to action. The message from the world's leading stroke centers is clear, and urgent stroke in the elderly is not an inevitable consequence of aging. Through comprehensive application of evidence-based prevention strategies, the vast majority of strokes can be prevented even in very elderly populations. The 2024 American Heart Association guidelines provide a roadmap for effective prevention, emphasizing that it is never too late to reduce stroke risk. Whether through blood pressure control, dietary changes, physical activity, or appropriate medical therapies, each intervention contributes to substantial risk reduction. For elderly individuals, the path to stroke prevention begins with awareness and assessment. Understanding personal risk factors and working with healthcare providers to address them systematically can dramatically reduce stroke probability. The tools and knowledge exist. What remains is implementation. Healthcare systems must rise to meet this challenge by providing accessible, comprehensive stroke prevention services tailored to elderly populations. This includes addressing not only medical risk factors, but also social determinants that impact health outcomes. The ultimate goal extends beyond preventing stroke to promoting healthy aging and maintaining quality of life. When elderly individuals can avoid the devastating consequences of stroke, they maintain independence, cognitive function, and ability to engage with family and community. As our population ages, stroke prevention in the elderly becomes not just a medical priority, but a societal imperative. The research is clear, the guidelines are comprehensive, and the outcomes are proven. The time for action is now. Every elderly individual deserves access to effective stroke prevention. By implementing the strategies outlined by leading medical centers worldwide, we can dramatically reduce the burden of stroke and enable older adults to live their remaining years with vitality and purpose. The power to prevent stroke lies within our reach. We must only grasp it.